Thank you guys for joining this month's Grand Rounds video lecture series. We have Dr. Ashim Wadehra from our orthopedic specialists department, and he's going to be giving us a talk on flat foot reconstruction. So I'm going to let you take it away, Dr. Wadehra.
Yeah, thank you guys, and welcome to this month's Grand Rounds. As Suraj mentioned, I'm Ashim Wadehra. I am the foot and ankle surgeon here with Inside Orthopedic. And today I am going to be discussing flat foot, and more specifically flat foot reconstruction. I think flat feet is something that a lot of people deal with, and it's something that I see quite often. So a common question that I often get is, what exactly is a flat foot? And essentially, a flat foot is where the arch is no longer present for the patient. So if you look at the two pictures on the bottom, the diagram on the left, you don't really appreciate an arch for the patient whatsoever. Whereas on the right, the patient has a nice space, there's an arch, has somewhat of a more of a normal foot structure, if you will. And so oftentimes patients will come into my office with complaints of pain on the inside of the ankle or the medial aspect of the ankle. Also, patients will have fatigue in their legs. They just feel tired all the time because the foot and ankle are just not working like it should be. And then in some of the more advanced stages where the patients put this off for a while, you start to notice more global foot and ankle pain. And really the patient will start to experience more pain on the lateral side or the outside of the ankle. And oftentimes this is due to the fact that the outside ankle bone will literally abut the heel bone because of how flat the foot has become. I also will see patients that come in with the flat foot, but also are dealing with knee, lower back, and hip pain. And it's really interesting to see, once you stabilize the foot and ankle, whether it's from a conservative care, whether that be an orthotic or a brace or surgery, how some of these ailments kind of alleviate themselves. And that just goes to show you that really the whole body is connected together. So, you know, you can't just look at the foot and ankle as its own entity, or the lower back as its own entity, or the knee or whatever. They're all connected together. And so if one thing's thrown off, the body compensates to help alleviate the pain. And so again, interesting to see how a lot of these ailments do go away once you correct the deformity. There's a lot of different verbiage and nomenclature for flat feet. And here on the left are the most common terms you'll typically see. So pes planus is common. We often use in the foot and ankle world, we use posterior tibial tendon dysfunction, and I'll explain to you exactly what that is here in just a second. That's very commonly used today. Adult acquired flat foot's another term, pes valgus, and then now a new term is becoming more common. It's called progressive collapsing foot deformity. But if you look at the picture on the right, you can see, can you guys see my cursor, by the way? Do you guys see this? You guys hear me?
Yeah, we can see that.
Okay, great. So there's this long tendon right here following my cursor, and this is called the posterior tibial tendon. And it inserts right here inside the ankle bone called the navicular. And so what ends up happening is, when the patient starts to collapse, this tendon, and you can probably visualize this in your mind, will stretch over time. And in chronic conditions, this tendon becomes pretty much, it's non-existent anymore, and becomes very tendinosed, or it develops a lot of tendonitis, develops a lot of inflammation around the tendon itself. And then in some cases, you have what's called interstitial tearing, or complete tearing of the tendon itself. And then if you look at the picture here in the background, this is a really good example of what a flat foot looks like. So you see here on the left, this is normal. The patient's ankle's upright. Here you see ankle's kind of kicked out, and we call that hindfoot valgus. That's what that term is called. And then here you look at the toes, and you can see that you can see practically all the toes, and we call that too many toe sign. And so these are things that I also look for. So again, if you kind of look at the left versus the right, you could see the too many toes sign. You see the ankle kind of kicked out, whereas in this case, you can really only see the fifth toe. And then in normal feet, this is what you want to see. Just from behind, you want to see just the one baby toe. You don't want to see this heel kicked out like that. You want it to see it nice up and right. So the physical exam from a physical exam perspective is very important because this really dictates how you're going to treat the patient. But back to that posterior tibial tendon, first thing I like to do for the patient is basically palpate this tendon, feel the tendon, and oftentimes the patient's going to have a lot of pain in this region where this oval is at. And this is exactly where this tendon courses. And a lot of times in patients that are acutely inflamed, this tendon will be very bulbous in nature. You can even see it's protruding through the skin sometimes. It's that bad. And then I also like to assess for subfibular impingement. This is what we discussed in the first slide. And that is, again, on the outside of the outside ankle bone. And some patients will basically abut the heel bone due to how bad the patient's collapsed. I also like to assess all the ligaments, again, on the inside of the ankle, especially where this tendon is right behind it. You can see on this image here, right behind these tendons, you see this gray area here. This gray area is all the ankle ligaments. The ligaments hold the bones together and keeps the joints nice and aligned. But you can imagine over time, this tendon will stretch, but these ligaments will also stretch too. And sometimes this patient's the ankles also sort of tip into a valgus direction or more of an outward kick, if you will. I also do an examination called the heel rise examination. I'll show you that here in the next slide, but this is essentially testing the integrity of this posterior tibial tendon. Patients that have tearing or significant tendonitis of this tendon will not be able to go on their tippy toes, and that's essentially what this is. I also look for a condition called equinus. Now, equinus is literally it just means that the patient has difficulty bending the ankle up in the ankle joint. And we all of us here to a certain degree have an equinus deformity, but in certain patients, it's more pronounced. And this actually can be addressed when you're doing a flat foot or any really foot and ankle procedure. And then lastly, I check to see if this deformity is flexible or rigid in nature. And what I mean by that is I will manipulate the foot, and if I in my own hands can reduce the deformity and basically recreate the arch in my hands by manipulating the foot, that is considered a flexible deformity. Whereas if the patient's foot still sits in that collapsed position, I'm not really able to mobilize the joints very well. We consider that a rigid deformity. And oftentimes that basically means that the patient has a very arthritic foot structure. And one thing I do for all my patients besides standard x-rays is I also order MRI or CT scan. With more of the flexible deformities, I will order an MRI to better assess the soft tissue structures. If I'm leaning more towards the patient's rigid, I will mainly jump to a CT scan, and that'll help me to assess the joint structure. So again, back to the physical exam. Here, this depicts the posterior tibial tendon. I will run my hands through this area, palpate the region. But down here, this diagram is showing the heel rise examination. And so here, the top picture shows a normal heel rise. The patient's able to go on their tippy toes. But if you look at the bottom, this patient's trying to go on their tippy toes, but they're struggling. And the reason why is because this posterior tibial tendon right here, it's just super attenuated. It's no longer functioning like it should. And this is the tendon that allows your ankle to sort of go in that downward position. So you can imagine if this tendon is no longer functioning well, the patient's going to have a very difficult time going on their tippy toes. And in fact, this patient here, you can see the swelling in this patient. It's significantly swollen. And that's due to the fact that this whole area is just attenuated from this chronic condition. And again, we're looking at the too many toe sign. You can see here on the left, this patient, you can only really appreciate the one little toe, and that's really what you want to see. But here, in this case, this patient's so collapsed, this patient's foot is sort of kicked outwards, and you can see almost all, 5 toes, if you will. Now, it's always in my hands. I always try to go to a conservative approach before we discuss surgery with the patients. And so I find that with more deformities, the over-the-counter braces work well. They help to stabilize the foot and ankle. I also like to use an orthotic to help stabilize the foot and ankle. In some of the more advanced forms where the patient's not a great surgical candidate for whatever reason, we will jump to a custom orthotic and or what's called an Arizona brace. And an Arizona brace is basically a very beefed up version of this over-the-counter brace. It really locks up the foot. It can be a benefit to patients that are non-surgical, but some patients do find this to be very uncomfortable to wear. But it is definitely an option. And then I always try physical therapy for patients. Physical therapy, I think, works very well for foot and ankle. Whether the patient's a surgical candidate or not, physical therapy helps the patient work with strengthening the tendon, the ligaments, but also at the same time helps stabilize the knee, the hip, and even the back to a certain degree. And so I rely on physical therapy a lot for a lot of my foot and ankle ailments. So let's now jump to surgery. You know, we discussed flexible versus rigid. And if I have a patient that is flexible in nature and they need some sort of surgical procedure done from a flat foot perspective, I will utilize a combination of extra articular osteotomies. And this just means I'm making bony cuts away from the joints and I'm realigning the foot in a more corrected position. And again, so I'm leaving the joints alone. I'm not destroying the joints. The joints are usually supple in these patients. They're healthy in these patients. At the same time, though, you have to look at some of the soft tissue stuff too. We discussed that posterior tibial tendon. A lot of times these patients have inflamed tendons. The tendon's no longer working very well. And so what I will oftentimes do is do what's called a tendon transfer. And there's a tendon that sits next door to that posterior tibial tendon that in some cases I'll literally just take that tendon and transfer it over to where the posterior tibial tendon lives. And that does well for the patient. Now, for some of the more rigid deformities, I will perform fusions. I like fusions a lot. I have a very low threshold for fusions, but typically this is reserved for the patient that's rigid in nature, arthritic in nature. But I also reserve it for patients who are, more of the obese stature. If your patient is coming in, they're flexible in nature, but they're significantly overweight or they have a significant BMI, I'm going to have a low threshold to just fuse them because in my hands, I found that the fusion will hold up over time, whereas some of the extra articular osteotomies over time, they can lose their correction. So I find that the fusion works well. So basically what I do is, and I'll show you more examples with some of the cases I've done here. But I basically will go into the joint, I remove whatever remaining cartilage there is, and then oftentimes with these patients, they're arthritic and very arthritic, so there's not much cartilage left, and I'll realign the foot into a more corrected position. And what I mean by that is I'm basically building an arch for these patients, and then I hold it in place with the screws and the plates, as you can see depicted down here, and this does well for these patients. So I'm going to show you a few cases that I've done. This is a couple of these cases here I did recently here at Insight. A couple of them are from my fellowship and residency as well. But this is one I did on a patient not too long ago. 55-year-old female comes to me with significant foot and ankle pain. Just a real, exam findings are just classic symptoms: pain on the inside of the ankle, complete collapse of the arch. I did get an MRI for her, and even on the MRI showed significant arthritis throughout her joints. The global ankle pain, very significant flat foot. And so I assessed her with more of a rigid flat foot structure. So here are her preoperative x-rays, and I think it's important to see what I look at on here. So typically with the flat foot, what I noticed right off the bat is if you look at this lateral projection, the side view, you can see the heel bone here is very parallel with this weight-bearing surface. This bone should be more like that, angled, whereas this is super flat. And then I look at this structure all together, we call this the hind foot, and you can kind of see that this is depressed downward like this. This should be more upright, and you'll see exactly what I mean here in just a second. And then we come over to this image, and I do apologize for the quality of this image, but what I want you to really pay attention to is this right here. This is the talus bone. It looks like a round structure, and this bone right here is the navicular bone. And what we really should see is most of this bone should be covered by this bone, but really in this case, you can see that 50% of this bone is uncovered. And that is, again, clear-cut, classic textbook sign of a flat foot. And then also I want you to make note here, this lady does have a bunion too. And I also oftentimes find that the bunion does contribute to a lot of this flat foot pain. So oftentimes you'll see me stabilize the bunion when I do my correction. So let's move over to what I did for this lady. So these x-rays are, I think, 3 months after surgery. I rebuilt her whole arch. Now you can kind of appreciate this. This is no longer parallel. This is more upright like this. And I want you to be aware that this is never going to be perfect for the patients. You know, I do my absolute best to rebuild the arch, but it's never going to be like it used to be when they were younger. We do our absolute best to try though. So I want you to pay attention here. Look at this now. This round bone is no longer sitting out. It's covered completely by this navicular bone. I removed her bunny and I stabilized it completely. She healed very well. So I'll show you the before and after pictures now. So again, looking up top, the bunny is completely gone. This round bone is no longer uncovered. You can see it covered completely. And then on the side profile, you see how collapsed she is. It's now upright again due to this fixation I used. One thing to make note is with these patients, they're off their feet for quite some time. And I think with her, I think I kept her off her foot for almost 4 months. You can see here that here, you can see how white her bone is. This trabecular bone is nice and white. Whereas here, we call this disuse osteopenia. And that essentially means that there really hasn't been any stress through this foot because she's been off it. So it's very common to see this. And so what I oftentimes will do is I supplement with vitamin D a lot. I like to use vitamin D for these patients. So I'll get them on vitamin D. I actually like to start vitamin D before surgery to get them optimized. And then I work with physical therapy to just really start strengthening the muscles. And typically you find a year down the road that this usually starts to fill back in and they do pretty well. Here's another one I did recently. 65-year-old, same situation, and you're gonna see complete collapse of the arch. I mean, this is a lot worse than the other one. Complete collapse, very hard to make, you know, appreciate these joints. Here you can see complete uncovering of this talar head, this ball-like bone. Again, 50% of it is uncovered, and you can see what I did for her here. Now she's not completely healed just yet. These images were taken, I think, maybe 2 months after surgery, so she's not healed just yet. But you can appreciate the head's covered again. Now, mind you, these are non-weight-bearing images, but you can really appreciate that this bone is back upright, it's stabilized. And so she's doing well, but she's not out of the post-op rehab just yet. This is a case I did in my residency. Now, this is a pediatric flat foot, 11-year-old female soccer player, very significant flat foot deformity, and you can see it through the images here. Very significant uncovering of this talar head once we realign her foot. Now, mind you, we used extra articular osteotomies for her. You can see how nice and covered this is again. Here on the side profile, again, you can see these lines depicting this sort of depression or this sort of hindfoot complex is kind of dipped down, whereas when we realign her, you can see how this is nice and upright again. You can see where we made the bony cuts in her foot, I'm sorry, her ankle bone, heel bone rather, and then I've used K-wires to hold this in place. These are just pins. Now, something to keep in mind with pediatric population, these patients have growth plates that are immature. So you can see these lines here. Patients oftentimes get confused and they think these are fractures. These are not fractures. These are indeed just open growth plates. So she had an open growth plate back here and we elected to do the surgery, but instead of using screws, which can prematurely close these growth plates, we elected for smooth K-wires, which in kids do very well. And really, if you come to me and the patient is a kid and they had a fracture or something that needs to be fixed surgically, oftentimes we're going to be using the K-wires to prevent the growth plates from being compromised too soon. And here's another one, adult patient with global ankle pain, but flexible in nature. In this case, we use screw fixation. And again, you can appreciate the hindfoot complex back upright again. We did some soft tissue rebalancing as well. So all in all, what I tell patients, this is the end of my presentation, but what I usually do for the patients is I tell them, listen, it's going to be about a 3-month ordeal of intense rehab. I keep them off their foot for a good 3 months, and then we get them weight bearing into a boot, followed by physical therapy. And so again, with any foot and ankle procedure, one thing to keep in mind is that I tell the patients, you know, your bones will typically heal within 3 to 4 months, but the one thing that you need to keep in mind is the swelling. I think patients underestimate this. Foot and ankle surgery is very different from any surgery you're ever going to have. And the main complaint that I will see is swelling. Swelling can last a good 6 months, a year to even a year and a half after surgery. And we do our absolute best to combat that, but unfortunately, you know, this is just the nature of the game and how it is. The foot is furthest from the heart, closest to the ground, and blood naturally will pool to this area. Again, even after a year after surgery, very common to see that. So well, that's the end of my presentation. I can take a few minutes here to answer some questions, but I unfortunately do have some patients waiting on me, but I could take about 5 minutes if anyone has questions for me.
All right, thanks, Dr. Wadehra. And I've allowed everyone to unmute themselves. So if anyone has a question, feel free to unmute yourself, or just type it into the chat box, and I'll relay it to Dr. Wadehra. So if nobody's going to ask any questions, I'm going to ask. So is this something that can develop over time? So if you have a normal arch, and then you may have went over this and I just missed it, but if you have a normal arch, can your foot eventually become flat with age?
Absolutely can. Yeah, absolutely can. And it is genetic to a certain degree too. You know, you have patients that'll come and say, hey, you know, my grandma has this, my mom has this, and so to a certain degree, it is genetic. But oftentimes too is you really see this also in the more of the obese population. You know, there's the patients holding a lot of weight, and
Right.
so that, you know, your ankle can only hold so much weight. And so over time, you know, as we discussed, you know, your body needs to adapt. And so one way of adaptation is flattening out to compensate for all that weight you're carrying.
Yeah, that makes sense. Thank you for answering that. If we have any other questions, please let us know. Dr. Wadehra actually has to go see a patient. So if nobody has any other questions, we're going to let him go. And again, if you guys are not following us on social media, please do. Thanks for attending, and we'll see you next
Sorry,
time.
just one last question. Can you guys hear me?
Yep.
Yeah.
Hey, Dr. Ware. So, quick question. So, can you talk to us a little bit about return to sport after like a flat foot reconstruction? How are athletes able to return to sport? Are they near 100% after like a flat foot reconstruction?
So, you know, here's what I tell patients that are active. You know, I always tell them, first of all, give yourself a whole year to feel like yourself again. It does take that long. And I'm not just speaking from a flat foot reconstruction. I'm talking about any sort of procedure, but specifically from a flat foot. You know, these patients are typically, they're not your, you know, your LeBron James of the world, right? They're just normal kids or your weekend warriors, if you will. Okay. Um, so I tell them, give yourself a good year to feel like yourself, to really get back to those activities that you love. That gives you enough time to get through the rehab process, to really strengthen up those tendons, ligaments. And again, I'm going to harp on the swelling perspective, because swelling is what really sets people back. And so giving yourself that year to really let the swelling to calm down. I don't see there being an issue with getting back to some of those activities. Are you going to be the star athlete you maybe were in high school? No, you're never going to be that star athlete. But I can definitely see you getting back to playing some basketball with your friends on the weekends, doing some jogging, you know, stuff like that.
I see. Thank you.
All right. Again, thank you. If there are no more questions, we're going to just conclude. So thanks again, Dr. Wadehra, for giving us that presentation.